Bismillahirrahmanirrahim. Assalamualaikum. My name is Arshbalani from BS Chemistry. Today my presentation topic is human head transplant to another body. So these are the presentation outlines here: introduction, scientific foundations, key figures and milestones, surgical procedure overview, technological and medical challenges, ethical and philosophical considerations, legal and regulatory issues, public reaction and media coverage, future directions, conclusion, references. So let's start this. First of all, introduction to human head transplantation. Head transplantation, also known as a cephalosmatic anastomosis, refers to the surgical procedure in which a living human head is transferred from one body to another. This concept is distinct from brain transplantation, which would involve removing and implanting only the brain into a different skull or body, a feat that remains far beyond current medical capabilities due to the brain's extreme sensitivity and the complexity of its integration with the nervous system. In head transplantation, the entire head, including the brain, skull, eyes, and facial structure, is preserved and surgically connected to a donor body. The procedure would require the reconnection of the spinal cord, blood vessels, trachea, esophagus, and other critical anatomical structures. The goal is to maintain the consciousness, identity, and cognitive functions of the recipient while replacing their diseased or damaged body with a healthy one. Brain transplantation, on the other hand, is broadly theoretical and presents even greater challenges. The brain lacks the regenerative capacity to survive removal and reimplantation, and the intricacies of connecting billions of neurons to a new spinal cord and peripheral nervous system are currently in insurmountable. Thus, while both concepts are radical, head transplantation is considered more feasible, though still highly controversial and ethically fraught. Historical context and early experiments. The idea of transplanting a head or brain has fascinated scientists and philosophers for centuries. Early anatomical studies and surgical experiments laid the groundwork for modern transplantation science, but it was not until the 20th century that serious attempts were made to explore head transplantation in animals. One of the most earliest and most famous experiment was conducted in 1908 by Charles Guthrie, an American physiologist who attempted to graft the head of one dog onto the body of another. Although the transplanted head showed some signs of life, such as blinking and movement, it ultimately failed due to lack of proper vascular and neural integration. In the 1950s and 60s, Soviet scientist Vladimir Demikov conducted a series of head and organ transplant experiments on dogs. He successfully attached a second head to a dog body, creating two-headed animals that could both eat and react to stimuli. This experiment, while gross by today's standard, demonstrated the possibility of maintaining partial function in a transplanted head. The most notable advancement came in 1970 when Doctor Robert White, a neurosurgeon at Case Western Reserve University, performed a head transplant of a monkey. White removed the head of one monkey and attached it to the body of another. The transplanted head was able to see, hear, taste, and move facial muscles, but the monkey was paralyzed from the neck down due to the inability to reconnect the spinal cord. The animal survived for several days before succumbing to immune rejection and other complications. These early experiments were groundbreaking but also highlighted the immense challenges of head transplantation: the inability to restore motor function, the risk of immune rejection, and the ethical concerns surrounding animal welfare all posed significant barriers to progress. Motivation, medical conditions, and the search for solution. The motivation behind human hair transplantation is rooted in the desire to treat severe medical conditions that are otherwise untreatable. Patients suffering from terminal muscle wasting disease such as amyotrophic lateral spinal muscular atrophy or advanced multiple sclerosis may retain raw cognitive function while their bodies deteriorate. For these individuals, head transplantation could practically offer a new lease on life by providing a healthy body while preserving their mind and personality. Another potential application is for individuals with extensive bodily problems such as quadriplegics are those with irreversible organ failure. In such cases, conventional organ transplantation may not be sufficient and a full body replacement could be the only viable option. Dr. Sergio Canavero, an Italian neurosurgeon, has been one of the most vocal proponents of human head transplantation. He argues that advances in microsurgery, immunosuppression, and spinal cord fusion techniques, particularly the use of polyethylene glycol, make the procedure technically feasible. Canavero proposed procedure known as hammerhead anastomosis venture involves cooling the brain to reduce metabolic demands, severing the spinal cords of both donor and recipient and using reinforced nerve endings. The first proposed human voluntary body procedure was valvular Spiridonic, a Russian computer scientist was warning Hoffman disease, a rare form of spinal muscular atrophy. Spiridonov was expressed willingness to undergo the procedure despite the risk, citing the lack of other treatment options and the potential for a better quality of life. However, the surgery was never performed and Spiridonov later withdrew from the project. Scientific foundations. Anatomy and physiology of the head-body interface. The head-body interface is a complex anatomical junction involving multiple systems: the central nervous system, circulatory system, respiratory tract, mus musculoskeletal structures, and lymphatic and endocrine network. At its core lies the cervical spine, which houses the spinal cord, a vital conduit for motor and sensory signals between the brain and body. The anatomical structures include spinal cord and vertebrae. The spinal cord exits the brainstem through the foramen magnum and continues from the vertebral columns, severing and reconnecting. It is the most formidable challenge in head transplantation. Carotid and vertebral arteries. They supply oxygenated blood to the brain. Any interruption can cause irreversible damage within minutes. Regular veins are responsible for draining deoxygenated blood from the brain, trachea, and esophagus. These must be reconnected to restore breathing and swallowing functions. Peripheral nerves and muscles, facial expression, speech, and swallowing depend on precise nerve muscle coordination. The interface also include an autonomic nervous system which regulates involuntary function like heart rate and digestion. Disruption here can lead to systematic instability post-transplant. Role of the spinal cord, blood vessels, and immune system. Spinal cord. The spinal cord is the most critical and least forgiving structure in heart transplantation. It consists of millions of neurons and glial cells organized into ascending and descending track-based track carrying motor demands from the brain to the body and sensory information back to the brain. Challenges in spinal cord reconnection. Axonal regeneration. Adult CNS neurons have limited regenerative capacity. Scar information injury triggered behavioral scale which inhibits reconnection. Functional integration. Even if axons reconnect, destroying coordinated movement and sensation. is uncertain. Researchers have proposed using polyethylene glycol, a fusogen that may help fix severe eczema and promote reconnection and most studies show partial success, but human trials remain unproven. Blood vessels maintaining cerebral perfusion is essential. The brain consumes 20% of the body oxygen and is highly sensitive to ischemia. During transplantation, the head must be cooled to reduce metabolism. Another technique known as hypothermic neuroprotection. Key vascular concern rapid anastomosis as arteries and veins must be reconnected within minutes. Hemostasis and clot prevention with scopal thrombosis or hemorrhage is high monitoring and intracranial pressure swelling or poor drainage can cause brain damage. Most microsurgical techniques and robotic assistance may improve precision and speed during vascular reconnection. Immune system. Although the brain is partially protected by the blood-brain barrier, the head contains tissues, skin, muscles, bones that are immunogenic. The recipient immune system may recognize the donor body as foreign, triggering rejection. Immunological challenges: graft versus host disease. If immune cells from the donor body attack the recipient head, host versus graft rejection. If the recipient immune system attacks the donor body, immunosuppression. Long-term use of drugs like um, tacrolimus or cyclosporine is required, increasing infection risk. Some researchers suggest using genetically matched or cloned bodies to reduce rejection risk. All this raises ethical concerns. Neurosurgical and transplant technique require surgical planning. A head transplant would require a multidisciplinary trained neurosurgeon, muscular surgeon, anesthesiologist, immunologist, and rehabilitation specialist. The procedure may take over 36 hours and involve two synchronized operating rooms, one for the donor body and one for the recipient. Head steps include cooling the brain, reduces oxygen demand, and protects neurons. Severing the spinal cord done with ultra-shock blades to minimize trauma. Vascular anastomosis, reconnecting arteries and veins using microsutures, spinal cord fusion, applying PEG or other agent to promote axonal reconnection. Trachea and esophageal reconnection restores breathing and swallowing. Muscle and skin closure ensures structural integrity and appearance. Post Post-operative care recovery would be intensive and prolonged. The patient would require mechanical ventilation, nutritional support for feeding tube, physical therapy for motor function, physiological counseling to adapt to the new body, neuroplasticity, the brain ability to adapt may help the patient control the new body, but outcomes are unpredictable. Experimental techniques. Electrical stimulation may promote spinal cord regeneration. Stem cell therapy could aid in neural repair. Interfaces might assist in motor control if spinal fusion fails. After surgery can develop a post-Hammad protocol incorporate many of these ideas, though it remains theoretical and controversial. In summary, the scientific foundation of human head transplantation involved navigating the most complex anatomical and physiological system in the body. While advances in microsurgery, immunology, and neurobiology offer hope, the procedure remains speculative and fraught with technical and ethical challenges. Key figures and milestones. Dr. Sergio Canavero, the architect of human health transplantation. Dr. Sergio Canavero is an Italian neurosurgeon who gained global attention to 2015 when he announced plans to perform the world's first human head transplant. Born in Turin in 1964, Canavero studied medicine at the University of Turin and became known for his work in neuromodulation and spinal cord stimulation. However, it was his bold proposal for a procedure called Hammad that catapulted him into the spotlight. Canavero's vision was to surgically remove the head of patients suffering from a terminal heart disease and turn it into a healthy donor body. Claimed that advances in microsurgery, immunosuppression, and the spinal cord fusion protocols, the use of polyethylene glycol made the procedure technically feasible. EGF was proposed to have reconnect severe axons the spinal cord, potentially restoring motor function. In 2017, Raul had his team conducted a rehearsal procedure using two cadavers, demonstrating the technical steps of the transplant while no human surgery was performed. The event was widely publicized and criticized. Many in the medical community dismissed the idea as uh, citing the lack of peer-reviewed evidence and the ethical implications of such an experiment. Despite skepticism, Canavero remained undeterred. He collaborated with Chinese surgeons at Harbin Medical University, where he was named as honorary professor. He claimed that China's regulatory environment was more conducive to medical experimentation and hinted that this first-like procedure might occur there. However, no verified human head transplant has taken place to date. Canavero's work sparked intense debates. Supporters hailed him as a visionary pushing the boundaries of medicine, while critics accused him of recklessness and ethical transgression. Biases like Paul Root warned that the procedure walks a fine line between medical care and murder, highlighting the risk of identity disruption, physiological trauma, and irreversible harm. Valery Spiridonov, the willing volunteer, Spiridonov, a Russian computer scientist born in 1984, became the first person to publicly volunteer to work at a neuroprotocol head transplant. Spiridonov suffers from Wernicke Hoffman disease, a severe form of spinal muscular atrophy that causes progressive muscle wasting and paralysis. Despite his condition, Pirno maintained full cognitive function and expressed a strong desire to improve his quality of life. In interviews, Pirno described his motivation as rooted in desperation and hope. He acknowledged the risk, but he believed that the procedure could offer a chance at a normal life. His decision was met with both admiration and concern. Some viewed him as courageous, while others questioned whether he was being exploited and or misled. Spiritual involvement brought a human face to the abstract concept of head transplantation. His story was widely covered in international media and he became a symbol of the ethical complexities surrounding experimental medicine. However, as legal and logistical challenges mounted, Smirnov eventually withdrew from the project. He later married and became a father, choosing to focus on family life and more conventional treatment. His withdrawal did not end the conversation. It highlighted the need for moral, ethical oversight, informed consent, and physiological support in experimental procedures. Case remains a poignant reminder of the human space involved in radical medical innovations. Animal experiment, monkey, dogs, and rat. The foundation of head transplantation lies in the field of animal research, some of which dates back to the early 20th century. These experiments, while controversial, providing insight into the technical and biological challenges of the procedure. Vladimir Dimitrov two-headed dogs. In the 1950s, Soviet scientist Vladimir Demigod conducted a series of experiments in which he grafted the head and forelimbs of a monkey into the body of another dog, resulting two-headed dog could walk, eat, and respond to stimuli. Though they survived only for a few days. Demigod worked as a pioneer in organ transplantation and demonstrated the feasibility of vascular and tissue integration. Dr. Robert White monkey head transplant in 1970. American neurosurgeon Dr. Robert White performed a head transplant on a rhesus monkey. He removed the monkey head and attached it to the body of another. The transplanted head was able to see, hear, taste, and move facial muscles, but the monkey was paralyzed from the neck down due to then have already reconnect the spinal cord. The animal survived for several days before dying from immune rejection. White experiment was a landmark in neurosurgical and raised before ethical questions. He argued that the procedure could one day help humans with terminal body diseases, but critics condemned it as crude and scientifically limited. Rodent models and PEA research. More recent experiments have focused on rats and mice, particularly in testing PEA ability to fuse spinal and spinal cord tissue. Some studies supported partial restoration of motor function after spinal cord severance and PEA application. However, results has been inconsistent. Transplanting finally from rodent to human remains a major hurdle in some way. The journey toward human head transplantation is marked by bold visionaries, willing volunteers, and controversial experiments. Dr. Sergio Canavero and Valerie Spurgeon represent the human ambition and ethical complexity of this anti-war and animal research understood body possibilities and limitation of science. Whether head transplantation become a reality or remains provocative idea, its story continues to challenge our understanding of identity, medicine, and the boundaries of life itself. Surgical Surgical procedure on human head transplantation. Human head transplantation or Symptomatic anastomosis is one of the most ambitious and controversial surgical concepts in modern medicine. The procedure involves detaching a living human head from its original body and attaching it to a donor body with the goal of preserving the recipient's consciousness, personality, and cognitive function. This section outlines the surgical steps from pre-operative planning to post-operative rehabilitation, highlighting the immense technical and ethical challenges involved. Pre-operative planning and body selection. The success of hand transplant hinges on meticulous planning and precise coordination across multiple surgical teams. The procedure would require treating one for the recipient whose head will be transplanted and one for the donor whose head will be reused. Key concentrations include donor body selection. The donor must be brain dead but otherwise physiological, healthy, compatibility in terms of blood type, tissue type, and size is critical to reduce the risk of immune rejection and ensure anatomical alignment. Immunological methods such as organ transplantation, human leukocyte antigen matching is essential to minimize both versus host disease and rejection. Physiological evaluation. The recipient must undergo extensive physiological assessment to ensure they understand the risk and are mentally prepared for the profound identity shift. Surgical rehearsal, dry runs using CAD words or visual simulation help refine the timing and coordination of each surgical step. The surgical team would include neurosurgeon, vascular surgeon, anesthetic, immunologist, and rehabilitation specialist. Operation is expected to last 36 to 72 hours and involve over 100 personnel. Cooling and preservation of brain tissue. The brain is highly sensitive to oxygen deprivation in one of two manners. Without adequate blood flow can cause irreversible damage to mitigate less risk. Hypothermic neuroprotection is implied steps include induced hyper hyper hypothermia. The recipient had is cooled approximately 10 to 15 degrees using ice pack, cooled salad, perfusion, or specialized cooling thermal. This reduces the brain metabolic rate and oxygen cardiopulmonary bypass. Blood circulation may be temporarily maintained using extracorporeal membrane oxygenation or heart-lung machines. Uh, is make tolerant window cooling extended safe windows wisely from minute to hours for vascular reconnection. This phase is critical to preserving consciousness and cognitive function during the transplant. Severing and connecting the spinal cord, blood vessels and trachea. This is the most technically involved part of the procedure to involve small wisdom. Spinal cord severing the spinal cord is clinical at the cervical level, typically by severing using an ultra-short blood to minimize trauma. Alignment. The two spinal stumps must be perfectly aligned to facilitate fusion. Fusion polyethylene like rather fusion are applied to promote axonal reconnection. Reconnecting the spinal cord is a greater hurdle unlike peripheral nerve, central nervous system, and most have regenerative capacity even with the heavy fluid moderate sensitive blood vessel arteries and veins. The carotid and vertebral arteries as well as the jugular veins are reconnected using microsurgical techniques and sensitivity reperfusion must occur within minutes to prevent brain damage. Hemostasis, anticoagulant, and hemostatic agents are used to prevent clotting and bleeding, trapping and esophageal restoring airway continuity and allows for mechanical ventilation. Esophageal connect enables swallowing and gastrointestinal function. Other structures such as the vagus, thyroid gland, and lymphatic vessels may also be reconnected depending on feasibility. Recovery means speculative. Use of polyethylene glycol for spinal fusion. Polyethylene glycol is a synthetic polymer that has shown promise in promoting the fusion of severe exhaust blocks by severing damaged cell membrane and facilitating the reconnection of neuronal port. Mechanism of action. It acts as a collagen helping lipid membranes of shared exon 1. It reduces calcium influx and prevents secondary injury. It animal models e.g. has led to partial restoration of motor function of the spinal cord. Transition application in surgery is applied immediately to spinal cord alignment. It may be combined with electrical stimulation or stem cell therapy to enhance regeneration. The fusion site is stabilized using bioresorbable scaffolds or spinal fixation or hardware. While promising PEG effectiveness in human remain unproven, clinical trials are needed to validate its safety and efficacy. Post-operative care and rehabilitation. Recovery from a hand transplant will be long, complex, and uncertain. The patient would require intensive care and lifelong monitoring, immediate post-op care, mechanical ventilation until the patient regains autonomous breathing, immunosuppression, drugs like tacrolimus, cyclosporin, and corticosteroids are administered to prevent dejection. It may be combined with electrical stimulation or stem cell therapy to enhance regeneration. The fusion site is stabilized using bioresorbable scaffolds or final fixation hardware. While promising PG effectiveness in human remain unproven, clinical trials are needed to validate its safety and efficacy. Neuromonitoring, EEG, MRI, and neurological exam assess brain function and detect complications. Rehabilitation. Physical therapy aims to restore motor control, balance, and coordination. If spinal fusion is successful, the patient may regain partial movement. Occupational therapy helps the patient adapt to the new body and relearn daily tasks. Physiological support essential for coping with identity changes, body dysmorphia, and emotional trauma. Long-term concentration, chronic immunosuppression, increased risk of infection, cancer, and metabolic disorder, neurological operation must wire itself to control a new body process that may take months or years. Ethical oversight, one evaluation, ethic board, and medical root panels in assessing conclusion. The surgical procedure for human head transplantation is a monumental undertaking that pushes the boundaries of medicine, neuroscience, and ethics from pre-operative planning to post-operative rehabilitation. Each step involves cutting ethically and resolve challenges while the concept being broadly clinical and practical transplant and research into spinal cord repair, regeneration, and the nature of human identity. Technological and medical challenges reconnecting the spinal cord and restoring motor function. The spinal cord is the primary control core motor and sensory signal between the brain and body somewhat and reconnecting it is the most critical and least understood step in head transplantation. Unlike right now, the central nervous system has limited regenerative capacity to challenges axonal fusion. Spared axon must be clogged to restore motor pathway for ethylene glycofusion has shown promise in animal models by sealing axonal membranes and promoting regrowth. However, human trials in scar formation, injury causes severe scarring, which inhibits axonal regeneration strategies to reduce scarring, anti-inflammatory agents, and stem cell therapy functional integration in axons reconnect, restoring coordinated movement and sensation, quality cell alignment, and neuroplasticity, electrical stimulation, and neuroprosthetic may assist the both food recovery when speculative with the successful final cord fusion. The recipient would remain paralyzed from the neck down, undermining the procedure purpose. Preventing immune rejection and infection. Head transplantation involves joining two genetically distinct organisms, creating a high risk of immune rejection. The immune system against the donor body is foreign, leading to growth immunological concerns. Host versus dot immune rejection. The recipient immune system may attack donor tissue, especially skin, muscle, and organs. Dot versus host disease. If immune cells from the donor remain active, they may attack the recipient head. Immunosuppression drugs like tacrolimus and cyclosporin are required to suppress immune responses. Long-term use increases susceptibility to infections, cancer, and metabolic disorders. Infection risk, surgical site infections, the procedure involve multiple anastomosis and open wounds, increasing systemic infections, immunosuppressed patients are vulnerable to opportunistic pathogens, new infection breaches in the blood-brain barrier may allow pathogens to enter the CNS. Advanced biological methods provide the clinic and lifelong monitoring are essential to mitigate these risks, maintaining cerebral blood flow and oxygenation. The brain is highly sensitive to Xemia, even brief interruptions in blood flow can cause irreversible damage during transplantation. Maintaining cerebral perfusion is critical. Vascular challenges, rapid anastomosis, the carotid and vertebral arteries along with regular veins must be reconnected within minutes. Microsurgical precision required to prevent thrombosis or hemorrhage. Hypothermic neuroprotection cooling the brain reduces metabolism while extending the safe window. Techniques include ice packs, perfusion cooling, and is sport. Monitoring intracranial pressure. Swelling or door drainage can lead to brain herniation. ICP must be continuously monitored and managed. Failure to maintain adequate oxygenation can result in brain death, defeating the purpose of transplant. Long-term viability and physiological Integration. Even if the transplant is technically successful, long-term survival and physiological adaptation remain uncertain. The recipient must adjust to new body, altered sensory feedback, and potential identity disruption. Neurological adaptation. Neuroplasticity. The brain may rewire itself to control the new body, but this process is slow and unpredictable. Rehabilitation and brain-computer interfaces may assist phantom sensation mismatch sensory input may cause confusion, distress, motor learning. The patient must relearn basic movement, balance, and coordination. Physiological challenges, body dysmorphia. The new body may feel alarm leading to anxiety or depression. Identity crisis. The feeling of two individuals raises philosophical question about self-worth. Is the person still the same? Social reintegration. The patient may face stigma, media attention, legal ambiguity regarding identity, and why ethical consideration inform consent. Patient must fully understand the risk, including that paralysis and psychological trauma. Quality of life. Even with survival of patient life may be severely limited. Medical ethics. Critics argue that the procedure may violate principles of non-malfeasance and human dignity. Supporting technologies and future direction to overcome these challenges. Researchers are exploring advanced technology. Stem cell therapy may aid spinal cord regeneration, reduce immune rejection, neuroprosthetic devices that bypass damaged nerves to restore movement. Robotic surgery enhances precision vascular neural reconnection and assists planning stimulates surgical outcome and optimizes protocols. While promotion these technologies are still in development and have not been validated for head transplantation. Conclusion. Human head transplantation remains a critical and ethical contentious procedure. The technological and medical challenges, spinal cord fusion, immune rejection, cerebral fusion, and physiological integration are immense. While advances in neuroscience and surgery offer hope, the risk and unknowns strongly outweigh the benefit. Continued research in spinal cord repair, immunology, and neurorehabilitation may one day make such a procedure feasible, but for it now it remains a provocative frontier in medical science. Ethical and philosophical consideration. Identity and consciousness. Is the person still the same? One of the most debated questions in head transplantation is whether the recipient remains the same person after the procedure, since the brain houses memory, personality, and consciousness. Many argue that the individual identity is preserved. However, the body also contributes to one's sense of self through sensory feedback, hormonal regulation, and physical appearance. Philosophical perspective. Dualism through embodiment partition. Dualism posits that the mind and body are separate, suggesting identity residue in the brain in contrast. Embodied recognition theories argue that the body and brain are interdependent, shaping consciousness. Continuity of self. If the brain remains intact, legal and physiological identity may persist, yet drastically in physical form could disrupt the recipient's self-perception and social identity. Legal implication. Who is the legal person? Post-transplant, the head donor or the body? This has ramification of our citizenship, inheritance, and criminal responsibility. Legal implication. Who is the legal person post-transplant, the head donor or the body donor? This has ramification for citizenship, inheritance, criminal responsibility. The question is the person still the same, has no clear answer, and may vary depending on cultural, legal, and philosophical framework. Consent and psychological readiness. Informed consent is a cornerstone of medical ethics for a procedure as radical as heart transplantation, ensuring true understanding of voluntary agreement is especially critical. Challenges to informed consent. Uncertainty of outcome. The procedure has never been performed on humans, making risk and benefit speculative. Cognitive biases. Desperation due to terminal illness may impair judgment, leading patient to accept extreme risk. Therapeutic aim is conception. Patient may believe the procedure is more likely to succeed than evidence suggests. Psychological readiness. Body Morphia adapting to a new body may cause distress, anxiety, or dissociation, post-traumatic stress. The experience of transportation and recovery could trigger PTSD, identity confusion. The mismatch between mental self-image and physical form may lead to existential crisis. Pre and post-operative psychological support is essential, but even with counseling, the mental toll may be profound and unpredictable. Religious and cultural perspective, religious and cultural beliefs play a significant role in shaping attitude toward medical intervention, especially those involving the body and soul. Religious viewpoints. Christianity. Some Christians argue that head consultation interferes with divine design and the unity of body and soul. Others emphasize compassion and the potential to alleviate suffering. Islam scholars are divided. Some view it as tampering with God, creation, or while others may permit it under the principle of necessity. The Taoific saves life. Hinduism and Buddhism, these traditions often emphasize karma and the continuity of consciousness. A new body may disrupt karmic balance or spiritual identity. Cultural concentrations in collectivist society, the body may be seen as part of familial or communal identity, making population are more controversial. Individuals where self-autonomy may justify radical procedures. They outline with the patient, which is understanding of spectrum perspective as crucial for ethical decision making and public acceptance. Implications for organ donation and body commodification had transportation blurred the line between organ donation and body ownership. Traditionally, organ and donated to save life by using an entire body for one person. This ethical dilemmas. Key concerns: scarcity of donor bodies. Allocating a whole body to one recipient may deprive multiple patients of life-saving organ equity and access. The procedure would likely to be expensive and accessible only to the wealthy, exacerbating and healthcare inequality. Commodification of the body. Treating the body as a replaceable versus reducing human beings to interchangeable parties could lead to unethical practices such as body trafficking or exploitation of vulnerable populations. Regulatory implications. Existing organization framework may not cover full body transplant. New policies would be needed to govern consent, allegation, and oversight. Ethicists warn that without strict regulation, health transportation could open the door to a dystopian market for bodies. Conclusion: human health transportation is not just a surgical challenge, it is a moral and philosophical frontier. It forces us to confront fundamental questions about what it means to be human, where identity resides, and how far we should go in the pursuit of life extension. While the procedure may offer hope to some, it also demands rigorous ethical scrutiny, cultural sensitivity, and legal foresight. Until these issues are resolved, head transplantation remains more a thought experiment than a viable medical option. Legal and regulatory issues. Um, Human head transplantation, while theoretically possible, remains legally and ethically uncharted territory. The procedure challenges the existing framework in medical licensing, human experimentation, and international ethics. As such, an attempt to perform it would require navigating a complex web of jurisdictional, legal and regulatory barriers. Medical licensing and jurisdictional barriers. Medical licensing laws vary widely across countries and regions, and they govern who can perform surgeries, when they can be performed, and under what conditions. Has transplantation being untrustworthy Unprecedented does not fall neatly within existing surgical categories. Key licensing challenges. Surgeon qualification. Most countries require surgeons to be licensed and certified in specific specialties. A head transplant would involve neurosurgery, vascular surgery, transplant medicine, food and rarely overlap. Coordinating such a team across borders raises credentialing issues, hospital accreditation facilities must be approved to conduct high-risk surgeries. Non-hospitals currently have protocols or infrastructure for head transplantation, making institutional approval difficult. Cross-border collaboration, if the procedure is planned in one country but involves experts from other licensing, reciprocity and liability become major concerns. For example, Dr. Surgery will propose conducting the surgery in China due to receive regulatory flexibility, but the risk system more oversight and accountability. Jurisdictional complexity. Legal identity post-transplant. Determining the legal identity of the patient becomes ambiguous. Is the person legally the head donor or the body donor? This affects citizenship, insurance, and legal responsibility. Medical malpractice. In the event of complications or death, assigning liability would be challenging. Existing malpractice laws are not designed for such radical procedures. These barriers suggest that any attempt at head transplantation would require new legal frameworks of special exemptions, credentialing issues, human experimentation laws. Human experimentation is governed by strict ethical and legal standards designed to protect participants from harm and exploitation. Head transplantation, being experimental and high risk, would fall under these regulations. Key legal principles. Informed consent. Participants must be fully informed of risks, benefits, and alternatives given the unknown of head transplantation. Achievable to informed consent is difficult. Risk, benefit analysis, institutional rewards, and ethics made it most evaluate whether potential benefit justified risk in the case of head transplantation. Risks include death, paralysis, psychological trauma, and identity disruption. Vulnerable population. Patients with terminal illness may be considered vulnerable and more susceptible our declaration was required additional framework for such individuals. International Standard Declaration of Helsinki. This foundational document outlines ethical principles for medical research involving human surveillance, emphasizes respect for autonomy, beneficence, and justice. Belmont report defines ethical principles and guidelines for human research, including respect for person, beneficence, and justice. A clinical trials evaluation require rigorous review and approval for experimental procedure, including the transparency and data protection. Violating this standard could result in legal sanction, professional censure, and loss of medical licensure. International medical ethics standards for head transplantation would likely involve international collaboration. Global ethical standards must be considered with standarding to ensure that medical innovation respect human dignity and right. Core ethical principles of autonomy. Patients must have the freedom to make informed decisions about their care. This includes understanding the psychological and existential implications of receiving new body. Non-male licensed physicians must avoid causing harm given the high likelihood of complication. Critics argue that heart transplantation violate this principle. Beneficence medical intervention should aim to benefit the patient. The uncertain of head transplantation make it difficult to guarantee benefit. Justice access to care should be equitable. Head transplantation would likely to available only to the ones raising concerns about fairness and resource allocation. Global ethical bodies. World Medical Association issued guidelines on medical ethics and human rights. It has not endorsed head transplantation and may propose its own ethical ground on As Kuvayo at the committee promote ethical study in science and medicine emphasizes cultural sensitivity and respect for human dignity. Cultural and legal diversity in some countries religious or cultural beliefs may prohibit some procedures. For example, country Kantian ethics emphasize bodily integrity while Islamic view may view it as tampering with divine creation. Legal system may differ in how they define personhood, consent, and bodily right. This complicate international approval and oversight. Conclusion: human health transportation present unprecedented legal and regulatory challenges from licensing and jurisdictional barriers to human exploitation more than international ethical procedure. While existing frameworks without new legal structure, robust ethical oversight, and global consensus had transportation means a theoretical concept rather than a viable manipulation. Public reaction to human head transportation has been on one time mix of scientific skepticism and media sensationalism and cultural fascination, often blurring the line between medical innovation and science fiction. The concept has brought intense being focused on ethical and popular domains with responses ranging from outrage skepticism from the scientific community, but Dr. Sergio Canaveras announced his intention to perform the world's first human head transplant. The scientific community responded with widespread skepticism. Neurosurgeons are atheists and transplant specialists who question both the technical feasibility and the ethical justification of such a procedure. Criticism includes final conclusion that expert argued that drone technology can not reliably reconnect where final part while Canada proposed using carefully is highly likely to fail and no peer-reviewed evidence quoting this inhuman is likely lack of clinical trial. No formal trials have been conducted to test the procedure safety or efficacy. The absence of animal model demonstrating full motor recovery further undermines credibility. Ethical concerns: many scientists view the proposal as ethically irresponsible, citing the high risk of death, paralysis, and psychological trauma. The procedure experimental nature raises questions about informed consent. Dr. Arthur Kaplan, a prominent bioethicist, called the idea genocide, while others liken it to medical showmanship rather than serious research. The skepticism reflects a broader concern that the procedure prioritizes efficacy over science. Sensationalism of scientific purity. Video hair transportation has often known more sensationalism into amplifying public intrigue while sidelining scientific purity. Headlines like World First Hair Transplant to Happen Next Year Operation Frankenstein have dominated news cycles, claiming the story as a dramatic breakthrough rather than a speculative proposal. Sensationalist element, dramatic language, terms like Frankenstein, surgery, mad scientist, and immortality quest evoke emotional reaction and draw attention, but distort the scientific reality. Focus on personalities coverage often centers on Dr. Gambiro's charisma and Valerie Pirno-Porridge rather than the medical details. This human trust and in the host engagement while oversimplifies the risk. Lack of peer review. Many articles suggest Canberra claim without referencing peer-reviewed studies or expert rebuttals, creating a one-sided narrative. Scientific critique in media. Some outlets have adopted balanced reporting system in interviews with skeptical scientists and atheists. For example, Nature and the Lancet have published critical analysis of the procedure, feasibility, and ethics. Documentaries and podcasts have explored the topic in depth, offering beyond perspectives on the science, philosophy, and cultural impact tension between sensationalism and critique reflect the media world role as both informative and entertaining, while public interest in high accurate scientific communication remains essential comparison to science fiction. Human human head transplantation has drawn frequent comparisons to science fiction, particularly iconic worlds like Frankenstein, reanimated exploit these comparisons so both as cultural references point and cautionary metaphor. Frankenstein parallel Mary Shelley Frankenstein explore the consequences of unchecked scientific ambitions like Victor Frankenstein Cannibal is portrayed as a visionary defined naturalism questions about hybrid and moral responsibility. The theme of hereditary deception, what happens when body and mind are mismatched, is central to both Frankenstein and most red hat translations are Euryman philosopher who control identity confusion is unique with an anxieties about head translation and the science influences the explosion urban and used in the shell explorers of consciousness transfer synthetic bodies and the ethics of immortality. Within the narrative often questions whether the soul herself can survive radical physical change or mirroring real-world physiological repair. While these comparisons are metaphorical, they shape public perception by framing head transplantation as a dystopian art and a negative reaction. Many express moral outrage viewing the procedure as unnatural or unethical. Religious groups often put it on ground of worldliness, insanity, and one design. Social media has amplified criticism with use of mocking the idea, expressing fear about simplification. Cultural differences in characteristic societies, the body may be same as interior family and community identity, making conflation more controversial in individualist cultures. Personal or autonomy can be justified radical procedure if they align with the patient wishes. Conclusion, public reaction and media coverage of human head transplantation reflect the complex interplay of scientific skepticism, media sensationalism, and cultural imagination. While the concept captivates an audience and challenges medical norms, it also raises serious questions about ethics, identity, and the role of science in society. The debate continues responsible reporting and real-world scientific inquiry will be essential to separate from fiction. Future directions, human head transplantation, while still radical, has inspired future direction, neuroscience, regenerative medicine, and surgical technology. These include treating neurodegenerative disease, advanced spinal cord care, integrating AI and robotics, exploring synthetic body replacement. Key in spinal cord regeneration for Italian glycol has shown potential in slim, square exons and promoting fluid animal models. Stem cell therapy may help regenerate damaged neurons and glial cells, improving the chances of functional recovery. Gene editing tools like CRISPR could be used to enhance regenerative progress, suppress and have effectors like venous scaling and electrical stimulation in vivo. Prosthetic may assist in reactivating motor circuit and retaining the brain-body interface. Robotic precision arms equipped with microsurgical tools can perform delicate tasks like vascular anastomosis and nerve alignment with sub-millimeter accuracy. Have feedback system and low surgery phase tissue resistance, remotely improving control and reducing error, and autonomous surgical modules may one day handle routine steps, freeing human surgeons to focus on critical decisions. Possibility of full body prosthetic and Aesthetic integration beyond biological configuration. Some researchers in the human body the first scenario was cellular essentially emerging head configuration with cybernetical enhancement, key development, ethical and philosophical implications would a person witnessing her bodies could this lead to form of digital immortality or transhumanism, while footballing was static of not yet viable for head complication, they represent a paradox could cover with biological processes in the future. Conclusion, the future of human head population is at the intersection of neuroscience, regenerative medicine, AI, and bioengineering. While the procedure remains speculative, its conceptual is driving innovation. Final frontier, surgical robotics, and synthetic biology advances in not only make head modification feasible but also transform how we treat neurodegenerative diseases, restore mobility, and refine human embodiment. Future directions: neurodegenerative treatment could help patients with ALS, SMATC, final regeneration advances in PEG, stem cells, and nanotech offer home AI and robotics may improve surgical precision and tolerance. Synthetic bodies for body post-therapy could be an alternative for conclusion. Feasibility technically possible in parts but not yet clinically viable. Ethical readiness society must debate whether what was discovered and future research needed in final peer ethics and identity science. And we got more hints here. Thank you so much.